we move on to the next session. First of all, let me get things right. I'm going to invite the chairpersons. Uh, Dr. J. David, sir. He is consultant and head critical care at Clinical Hospitals, Visakhapatnam. And Dr. P.S.V. Ramarao, sir. He is consultant critical care at Tirumala Hospitals, Visakhapatnam. I request both of you to chair this session. Again, there's a slight change in the order of the lectures. A lecture on Dexmedetomidine in Septic Shock by Dr. Ghanshyam Jagatkar. His consultant critical care, his head critical care at Medicover Hospitals, Hyderabad.
Dexmedetomidine in Septic Shock, fishing in the right of AGM 2019, where they try to look at the use of dexmedetomidine as a sedative agent and compare it to the usual sedative that we use and look at the mortality rates. A comment which was made by Dr. August about how the trial was done, and this is basically about that trial. So before I go into the trial, just to give you a brief about the background and the role of dexmedetomidine in critical illness. We know that dexam is a fantastic agent with respect to sedation and analgesia, and because of its unique mechanism of action, it induces sleep which is much more natural, and the reason why the incidence of delirium is significantly lesser when you use dexam as an agent for sedation as compared to the other sedatives. But what has also been shown in a large number of animal studies, small human studies, and in a lot of experimental data is that dexmedetomidine, when it's used as an agent for sedation and analgesia, it was also shown to have significant anti-inflammatory effects. And these anti-inflammatory effects seem to have certain organ protective impact on the patient. For example, the incidence of acute kidney injury was less in those group of septic patients where dexam was used as a sedative agent. Similarly, the incidence of hepatic injury or the incidence of ARDS was found to be slightly lesser when dexam was used as an agent, and this anti-inflammatory properties, so it was not controlled in any major randomized controlled trials. This was one of the rationales for the next trial. This was a trial published in NEGM 2019, where they tried to look at the outcome benefit. We know that dexmedetomidine has been shown to decrease the incidence of delirium, incidence of or the decrease the duration of mechanical ventilation, but we don't have major data with respect to the use of sedative agents and the mortality benefit. So this was one of the first trials where they tried to look at if you use dexmedetomidine as a sole sedative agent as compared to your other sedative agents, will that impact your mortality? So this was done in about 8 countries across 74 intensive care units. This was an open label randomized controlled trial where they compared the use of early dexmedetomidine versus the usual care. The usual care included propofol, midazolam, and the other opioids. But what was interesting to find was, even in the dexmedetomidine group, almost 78% of patients needed fentanyl, about 65% of patients needed propofol, about 3% of patients needed midazolam, and about 7% of patients needed both propofol and midazolam. So, though the trial was supposed to be exclusive dexmedetomidine versus the usual group, even in the dexmedetomidine group, they had to use other sedative agents, and one of the reasons was that we know that dexmedetomidine doesn't cause deep sedation. And many of the times, if you have a critical ill patient, especially patients who have been put on mechanical ventilation, where you might need deep sedation to control or take over his breathing, using dexmedetomidine as a sole agent may not be sufficient enough. That's why you need to supplement the dexam with other sedative agents. And the primary mortality that they, or primary outcome that they wanted to see was the 90-day mortality. They want to check if we use only dexam in patients with who are put on mechanical ventilation as compared to the usual sedative, does it make any difference with respect to mortality? What they found was With respect to mortality, at 90 days, there was no difference between either of the groups. However, in the Dexim group, there was a significant incidence of both bradycardia and hypotension, and we know pharmacologically that dexmedetomidine is an agent which can cause both bradycardia and hypotension. Now, there was a subgroup analysis uh, which was published recently in 2020 on the same investigators. What they tried to do was, if you look at the original study, there were close to about 3,000 change patients, about 1900 patients, 1950 patients in the Dexim group, and about 1950 patients in the usual care group. And all these patients were put on mechanical ventilation. So the subgroup analysis, what they did was, from the original study, two centers, one from Australia and the other from Switzerland, they tried to choose patients who were in septic shock. And they tried to look at, in these patients with septic shock, when they used dexmedetomidine as a sedative agent, did it make any difference with respect to the use of vasopressors? Now, again, we all know that when you use dexmedetomidine, it has a biphasic effect as far as the cardiovascular system is concerned. When you initially give the dose, there is a chance that it may cause hypertension because of the stimulation of the peripheral alpha 2b receptors, and subsequently there is hypotension and bradycardia. So what they tried to do in this subgroup analysis was, if you use dexmedetomidine as a sedative agent in patients who have sepsis and septic shock, will that make a difference with respect to their vasopressor requirements, right? Now, as I said, only two centers. Initially, there were about 74 ICUs, but here they took patients only from two centers, and primarily they tried to look at the median vasopressor requirements in the first 48 hours. So they tried to look at how much dose of vasopressor, total whatever vasopressor was required in the first 48 hours. Secondary outcomes were, what was the cumulative and the peak norepinephrine dose? Did the norepinephrine dose change from the baseline? And as a measure of whether dexmedetomidine decreased the vasopressor requirements, they calculated the norepinephrine equivalent dose by the MAP ratio. So this was the formula that was used to calculate the norepinephrine equivalent dosage if you had used, apart from noradrenaline, other vasopressors like adrenaline and vasopressors, right? So the baseline characteristics were not different among the two groups. However, if you look at the original data, there were close to 3,000 patients, but in subgroup analysis, they took only the patients who had sepsis and septic shock. So that kind of decreased the total number of patients. So there are only total 83 patients, of which about 44 patients were in the Dexim group and 39 patients were in the usual sedative care group. The baseline characteristics with respect to the age, the demographics, the comorbids, the organ functions, etc., 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 was not much of difference between these two groups. And when they tried to look at, or they calculated the vasopressor requirements, the first graph shows the median vasopressor requirements among the two groups. The red one is the Dexam group and the blue one is the control of the usual sedative care group. There was no statistical significant difference between the dose of vasopressors which were required. So both in sepsis, both in the dexmedetomidine group as well as the usual sedative care group, the total norepinephrine equivalent dose was similar at the end of 48 hours. However, when they looked at the mean arterial pressures, though there was not much of difference, the Dexam group was able to achieve a higher mean arterial pressures with the same the vasopressor requirements. And when they calculated the ratio between your norepinephrine equivalent dose by the MAP, indirectly suggesting that for the same dose of vasopressor that was used in the Dexam group, they were able to achieve a higher mean arterial pressures. So the norepinephrine equivalent dose to the MAC ratio was lower in the Dexam groups, implying that in the Dexam groups, for the same vasopressor requirements, they were able to achieve a higher mean arterial pressure, suggesting that there could be a probability that when you use dexmedetomidine in patients with sepsis and septic shock, your vasopressor requirements may be lower. Now, this appears counterintuitive, but the proposed mechanisms that were put forth was one, we know that patients with sepsis and septic shock have a significant sympathetic stimulation. So there is excessive release of your endogenous vasopressors, and on top of that, you give vasopressors externally to protect your blood pressure. So this overactivation of the sympathetic system can lead to desensitization of your norepinephrine receptors, and that is the reason why you can have severe vasoplegia, and that is the reason why your norepinephrine or your vasopressors may not be effective. So when you use an alpha 2 agonist like dextran or clonidine, and we know that they are centrally sympatholytic, there is a reduction in the release of endogenous catecholamines. And because the endogenous catecholamine dose is reduced, they saw an increase or early resensitization of the alpha 1 receptors, thereby a better response to the exogenous vasopressors that you give. So that was one of the proposed mechanisms which was thought of. Similarly, as I said, dexmedetomidine in a lot of experimental animal studies and small human studies has shown to exert significant anti-inflammatory effects. So that could be another reason why they thought that the vasopressor requirements were significantly lesser in the Dexan group. There was also one more local vascular mechanism which was proposed, which is basically when the use of alpha 2 agonists, the presynaptic alpha 2 agonists can lead to a upregulation of the postsynaptic alpha 1 receptors, which could be a probable mechanism why you see a higher vascular reactivity to the exogenous vasopressors. Now, there were a lot of limitations for this study, which was highlighted by the author. One, retrospective nature, subgroup analysis, and neither of these were pre-specified. So when the first trial was done, or the first original publication was done, where about close to 3,000 patients were involved in the trial, they did not mention anything about the effect of dexmedetomidine on the vasopressor requirement. So this was something which was thought post publication of the trial, and small numbers, retrospective study, subgroup analysis, which was not pre-specified. We all know that this decreases the statistical performance of any trial significantly. Secondly, if you look at the original trial, there the primary outcome that they tried to research was the effect of sedation on mortality. But subsequently, in this particular paper, they tried to look at the effect of sympathetic deactivation and the effect that it has on the vascular reactivity. Again, the intent of the study was completely changed from the original study. However, whatever the results we got from this paper, at most they can be seen as something of a hypothesis generating rather than being, applying them directly to a day-to-day practice. Now, is this concept about use of alpha 2 agonists to increase the vascular reactivity or the improving the sensitivity of the adrenergic receptors in patients with sepsis and septic shock new? No. Way back in 2010, there was a paper which in fact kind of highlighted this hypothesis where they suggested that we can use alpha 2 agonists to reduce the vasopressor requirements in septic shock. Again, this was backed by a large number of small trials where they saw that when clonidine was used for presensitization, a large number of patients who were exposed to clonidine before either cardiac surgeries or septic shock, in them the response to the external noradrenaline or other vasopressors was much better compared to those patients where the alpha 2 agonists were not used. And we all know that in patients with septic shock, hyperactivation of the sympathetic system should be avoided. So basically, again, this paper was not talking about what we found in the recent trial, where if you can blunt the sympathetic activity by the use of alpha 2 agonist, then there is a probability that you can increase the vascular reactivity of your external vasopressor, thereby one, the immunity response would be better. Second, the dose that you need to give to protect your blood pressures may be lesser. So, to conclude, yes, we know that dexmedetomidine, as far as sedative and analgesia, is a very well-known agent and is used extensively because of its unique properties in inducing a sleep which is very similar to natural sleep and thereby decreasing the incidence of delirium. However, these papers suggest that by using an alpha 2 agonist and thereby having a central sympathetic effect, decreasing the endogenous release of catecholamines, you may be able to resensitize the alpha 1 receptors, thereby probably you may have a better response to your exogenous vasopressor. So there is something that worthwhile to try, and in the future trials, one of the major problems with this trial was, as I said, though dexmedetomidine was supposed to be used alone, close to 70% of patients also received either opioids or propofol. So we need to look at in the future where you use only dexam as an individual agent and compare that with other sedatives, and maybe look at what happens to the vascular reactivity, what happens to the dosages of the vasopressor. So that's something that probably is going to be worthwhile. Thank you.
So, previous all study shows that there is no mortality difference, and also it causes hypertension and bradycardia. But as you said, it reduces the doses of vasopressors that may affect in future studies. We have to use this drug in a different way, in an effective way. Thank you, sir.